All right. And honest to God, I haven't had a chance to look at this lecture, so I'm going to wing it today. I think I do know heart failure, so I'll be okay with that. But I was tied up in test reviews most of the day. So give me a chance to sort of reorient myself and make sure I'm saying the right things. So this is chapter 35, just so you know, from Iggy. This is Iggy, your red med surge book. You can read over, these are your class objectives. Of course, using the Orem language with air, activity, normalcy, and all that stuff. So you can, lots of objectives. We got plenty of time. All right, so let's start with thinking about the primary concepts that we're going to deal with when we're talking about the cardiac issues. And certainly perfusion to the coronary arteries, perfusion to the rest of the body. And then we definitely need to talk about gas exchange, comfort, and immunity. So they're going to be interspersed with what we're talking about today. Probably going to spend most of my time on heart failure. One is, it's like one of the number one readmittant diagnosis. That's why we have a heart failure clinic. I don't know if you're aware of that. We're really trying to prevent readmissions with heart failure patients. So education is going to be key, you guys. Education is going to be key with compliance with medication, compliance with diets. So really important that we reiterate what they've already been told, maybe 1,000 times if you need to, but they need to be told again and again and again. This is why you keep coming back, because you're not following your fluid restriction or you're not following your sodium restriction. So we're going to spend some time talking about teaching as well. I'm sure you've probably read in your chart about your patient whether they had systolic or diastolic dysfunction. And all that really means is that if there's something wrong during contraction, that's systolic dysfunction. So if there's something wrong with contraction, that's systolic dysfunction. And if there's something during filling, that's a diastolic dysfunction. Now, before you get your panties in an uproar, you don't need to know. The physician's going to diagnose. That's their job. Our job is just to make sure that our patients taking their medications, we're assessing them, make sure there's no change in the patient. They're going to tell you in their notes whether it's systolic or diastolic dysfunction. We'll definitely talk about, there's two types of heart failure, right-sided versus left-sided. So we'll talk about what that looks like with regard to fluid volume excess and decreased tissue perfusion as well. Now I know and then they all are starting to document it with the ejection fraction. Years ago, we just used to write CHF. Now they're writing heart failure. That little r means reduced ejection fraction. So, and I know that from the 2D echo. So if I know that they have a reduced ejection fraction, and you see that EF there about 40%, that is definitely a big significant change, because our EF should be, if you remember from previous, 55 to 65. So it's definitely decreased cardiac output. And there's your nursing diagnosis or your collaborative problem right there. When you see heart failure, your brain should already think I have decreased cardiac output. So we definitely want to look at things that can affect how well that heart contracts. Coronary artery disease, if we have areas of ischemia or even injury or even infarction, hypertension, any kind of valve dysfunction. And that's why you really do want to know what the echo looks like, because the echo tells us how well the valves open and close. If I have a dysfunctional valve, it can cause regurgitation or backward flow if the valve doesn't close appropriately, or if I have a very narrow valve, it's resistant to getting that blood out of that chamber. That chamber is going to become enlarged. So if we had mitral stenosis, let's just hypothesize that. And we know that the mitral valve is between the left atria and the left ventricle. And if I have a stenotic valve and I can't get the blood to eject into the ventricle from the atria enlarges because that blood stays in there. I can't get all the blood out of the atria, and that atria will enlarge. Same concept if I have an aortic stenosis, because aortic stenosis, we're going through the aortic valve and we're trying to get out of the left ventricle. So if I have a stenotic, narrowed aortic valve, there's a lot of resistance and I can't get the blood out of the left ventricle enlarges. So really think about how well those valves function, how well they open and close. And that's why the echo is crucial. If somebody's admitted with heart failure, that's the first thing that your instructor is probably going to ask you is, what does their echo look like? Have we had one done yet? Have we not had one done yet? Anemia, because the patient becomes hypoxic, we're not carrying around oxygen, it can definitely affect how well that heart contracts. The heart doesn't like to be deprived of oxygen. So if they're significantly anemic, it can certainly affect how well that heart contracts. So that's systolic dysfunction. Preserved, so instead of the R being there, we have a little P. So we've got a normal EF, okay? A decent EF, a decent ejection fraction, 65%. Now we're looking at this non-compliant or stiff ventricle. So I'm trying to slap blood into a very stiff ventricle, and it's difficult to get that blood to eject out because I can't even get it into the ventricle. So when I can't eject that blood, my cardiac output decreases. My cardiac output decreases because I'm not filling the ventricle up appropriately. I'm not getting enough volume in that ventricle appropriately. You can see the causes down there. Hypertension is a big one. Somebody who has had uncontrolled hypertension, we really worry about diastolic dysfunction in these patients because that heart is working. Remember that afterload I talked about? That heart is having such a difficult time ejecting out the blood against so much resistance. Constrictive pericarditis, we'll talk about that a little bit later in this presentation, and then myocarditis as well. We'll talk about endocarditis as well. Septicemia, so somebody who's septic, the toxins in the blood sort of stun the heart and don't allow the heart to function appropriately. So we really do pay attention to the cardiac function when somebody comes in septic. And thyrotoxicosis, I think Deb Phillips just talked to you guys about that as well, getting that thyroid level under control. Etiologies in systolic and diastolic, they can be similar. Ventricular effects are different. Systolic dysfunction more common and can lead to diastolic dysfunction. And progression of heart failure depends on the ventricular remodeling. Are we having all this craziness going on with that cardiac muscle? And are we really having an effective squeeze or contraction to help them get out that cardiac output? If we've got this damage in this ventricular remodeling, that heart can't contract effectively. So here's your ventricular remodeling. Occurs after myocardial injury. So let's go back to that angina patient that I talked about. That unstable angina patient keeps getting chest pain, and we're not getting it under control. And they're popping all this nitro, and they end up coming in and they have some injury or infarction. Now we've got a problem because that part of that heart is lacking blood flow and it becomes hypoxic. And we have those changes due to the lack of oxygen. Increasing intravascular dimension, so not vascular, intraventricular dimension. So inside that ventricle, if we're not ejecting, that blood just stays there. The ventricle enlarges. So we're talking about cardiomegaly, that enlarging of that heart. Increasing collagen formation leads to fibrosis. And with fibrosis, we don't have that beautiful contraction of that heart muscle. It's scarred per se, if you want to make it a simple term. So fibrotic changes are almost like scar-like changes, and it's not as flexible and doesn't have the opportunity to contract as strongly. Progressive myocyte destruction, dysfunctional contractility, increases the myocardial demands, and here we go again, supply and demand, we've got to be in balance. Decreases perfusion to the whole heart, and then the heart needs oxygen. When we become hypoxic, now we have dysrhythmias. And, when I was going over the test review, dysrhythmias are different than rate issues. So tachycardia is a fast rate. Tachyarrhythmias means a fast, irregular heart rate. So one has to do with rate, one has to do with rhythm. Please don't confuse the two. All right, so left-sided heart failure. We used to call congestive heart failure because if you don't remember the flow of the blood through the heart, I'd probably go back and review that. So on the left side, which your left ventricle is the big pumper, that's the big guy. That's the big, strong left ventricle that ejects out to the body. When I can't get blood out of that left ventricle, it backs up into my left atria and then back up into the lungs. Okay, and that's where we call this congestive heart failure. We don't use that term anymore. We really use left-sided versus right-sided heart failure. And just like I said earlier, if we have this hypertension, we have all this resistance, and I can't get out the blood out of the ventricle, it's going to back up. So that's why we want the blood pressure to be under control. Coronary artery disease, maybe I'm not perfusing that part of the heart and it's not contracting well and blood is backing up. And again, valvular disease, and on the left side, it's going to be the mitral valve. On the left side, it's going to be the mitral valve. Not all cases include fluid accumulation. So when we always talk about congestive heart failure, we think of people having, crackles in their lungs and things like that. So you've really got to pay attention to what your patient looks like. There's systolic and diastolic. Again, is it due to contractility or is it due to the filling phase? Systolic is contractility of that left side. Diastolic is that filling of that left side. Right-sided heart failure. And the way that I think of right-sided heart failure, I think of, well, it's got to be something coming back from the lungs, one. So significant, I want you to write this in, significant COPD. There are non-compliant lungs and lots of pulmonary hypertension. And when I have pressure in that pulmonary artery, and that's what pulmonary hypertension is, when I have pressure in that pulmonary artery that's high, it's going to back into the right side of my heart. Now, if I have a left ventricular failure and it keeps going back, it's all connected. Do you see where that can connect? So definitely, if I started on the left side, it can eventually turn into both sides. A right ventricular MI, if you're thinking of that right ventricle and it's stunned and it's infarcted, maybe that right ventricle is not contracting at all. They'll see that on the 2D echo. They'll be able to see how well that right ventricle can contract. And then the pulmonary hypertension or COPD, very important that you pay attention to those things of, oh my God, he's been a smoker for 60 years and he's got club nails and he's got COPD and he's on all those meds that Stephanie talked about. You should suspect pulmonary hypertension. The way that we tell in the ICU the pressure in the pulmonary artery is a pulmonary artery catheter, which is something we're going to talk about the first week you come back from break. So don't worry about it yet, but we can measure with a pulmonary artery catheter the pressure within the pulmonary artery to say, yes, this person has pulmonary hypertension. Now, the right ventricle cannot empty completely for whatever reason. And when we think of volume and pressure in the venous system, everything backs up on the right side. Now we have all that peripheral edema, neck vein distension, everything systemic backwards. Now that makes sense on the right side. The other thing I want you to add to right-sided heart failure in an acute situation, rapid, you're going to learn about this next semester, is a pulmonary embolism. If I have a significant, and that's how they can tell that somebody died of a pulmonary embolism, is they'll see right-sided heart failure on the echo. They'll see that the right ventricle has just failed. So pulmonary embolism, if I have a clot that's a huge pulmonary embolism in the lungs or even in the pulmonary artery, I can't get past that clot. that right ventricle can't eject the blood, that right ventricle will fail. So it's a classic sign that they see if somebody dies of a pulmonary embolism is they have right-sided heart failure. Okay.
I have a question,
Go
Mrs.
ahead.
With that pulmonary embolism, like, and people, they come out of it and things like that. How does that, I know they end up getting on, like, say, blood thinners or something or whatever, but like, how does that work, then after for their heart and everything? Is that
So it really depends. I mean, I have people who have saddle PEs, and what saddle PEs mean is sort of sits over the carina, and like you'll see it like kind of hang over and like a saddle, like on a horse.
Mhm.
If there could be small little in the very small vessels in the lungs in the periphery, a patient may complain of chest pain. That's not going to be somebody who's going to end up dying from right ventricular heart failure from a big PE. This is a massive PE where it's just totally blocking blood flow. You can have small little PEs.
Okay.
Those patients, any of our patients that come in with PE, and you'll learn more about this next semester, yes, they will go home on anticoagulants. They will, we will pursue, why did this patient have a PE in the first place? But if we have this young person that dies abruptly, we say, wait a minute, let's take a look. And I don't know if you remember a couple years ago. Do you remember the show with, I think his name was Ty, that did the Build a House in Boardman? Remember they redid a house? I don't know if anybody remembers that. Anybody?
Yeah, I remember. The mom
Okay,
passed
good.
away.
Good. Okay. I don't know if you remember, she died 5 weeks after having her baby. She was 29 years old. And she told her husband, I said, I got to lay down. I'm kind of tired. And she had a massive PE. And that's how they found out was they saw on the autopsy, they saw the big right ventricular strain. Hers was significant. We have people that come in with PEs all the time, very little small ones. So it depends on the size and where they're at. So don't, think that every PE is fatal. Okay, it's not. I don't know if I answered your question,
Okay.
Nikki, or not.
No, that's a little better because when we're talking about this, it's just more the significant ones.
Exactly. Where I can't get blood flow out of the right ventricle because maybe there's a big clot in the pulmonary artery or a significant clot within that pulmonary system and things back up. Okay. But yeah, small little, like a lot of patients will come in with small little small PEs that cause just chest pain on the side, not a significant thing that caused them to have like a right-sided heart failure.
Okay.
Very smart though to get an echo on everybody who does come in with the PE to make sure that they don't have that right ventricular strain. High output failure, cardiac output's normal. So if we had a pulmonary artery catheter in, we can measure the patient's cardiac output caused by increased metabolic demands. So there's your hyperthyroid that you guys just learned about. And then in septicemia, our body has a systemic inflammatory response that the body goes, oh my God, I'm in an overdrive. So this increased metabolic needs of hyperkinetic situations. Anemia, we're trying to get more oxygen and blood flow to that heart. And you're putting out the output. So your cardiac output's fine. It's because we're hypoxic. Okay, so the output is fine. So if we measured the cardiac output, it would be normal or above normal. You're going to measure cardiac output next semester when we teach you hemodynamic parameters. Now, I'm doing a disclaimer. I repeat, I am not asking you which class. Okay, that's a stupid question to ask for a nursing test. But if you're reading your cardiology notes, it's kind of nice to know where your patient's at. If somebody says, oh my God, they're class 4, you know that they're very, very ill. But I am not going to test you on these classes. Is that clear? Has everybody got that? Somebody say yes.
Yes.
Yeah.
Thank you, thank you, thank you.
Yeah.
But I want you to know, because if a patient says to you, hey, I'm class 3, they're really limited. Fair prognosis, class 4, very subjective. So you might see NYHA somewhere by the cardiologist. So then you can act like you know what you're talking about when you talk to the cardiologist. So I'm just giving you background information. This is another one. This is the ACC or AHA heart failure. This is criteria based. I'm going to say this again. I am not going to ask you to tell me what the stages are. That's not what a nurse does. This is diagnosed by the cardiologist. I'm just giving you background information, okay? So depending on, do you see stage D? So if somebody came in and they said, oh, they're stage D, they're end stage, you guys. These are patients that we're thinking about possibly maybe hospice, and they've got a lot of interventions that we have to implement to keep this patient alive. Okay, so I am not, I repeat, going to ask you to memorize that previous slide or this slide. Pathophysiology, systolic and diastolic can occur secondary to myocardial injury. So I can have a heart attack. I had perfectly fine cardiac output, perfectly fine cardiac function. I have this heart attack. And now with this heart attack, now I've gone into heart failure. So we kind of talked about this again, the injury remodeling, you can read through that again, but just know that different situations or different disease processes can set us up for heart failure, excessive drug use, different things like that. So again, not for you to diagnose, it's for you to understand what to look for in the heart failure patient. We already talked about ventricular changes and the remodeling. So when we're talking about the pump and pumping, we're talking about the issue of contractility. We're talking about the issue of contractility, and that's why we look at the ejection fraction, because that tells me how well that heart can eject out that blood. And that's a good way to tell how well it's contracting. Next semester, I'm going to teach you some more stuff, but right now we just have the 2D echo that can tell us how well that ejection fraction is and how well that ventricle is contracting. So the other thing is, you can see as we progress, we can have rearrangement, we can have insufficiency. Mitral insufficiency, that could mean that blood can backflow from the left ventricle to the left atria. Now the left atria is enlarged. So you can see where all of this can sort of back up. You know, it's all connected. Compensatory mechanism. This is why I say you need to understand the patho, this part, because then you understand why you're giving the meds that we're going to talk about in a minute. So when the cardiac output's insufficient, the body senses that. And the first thing that happens is the sympathetic nervous system, think epinephrine, heart rate goes up. And with epinephrine, vasoconstriction. Okay, heart rate goes up and says, I need to pump faster. I need to pump faster so I can get a better cardiac output. And the vessels clamp down and say, well, I need to clamp down to help a better tone in those vessels. That can turn into a negative situation because it can make me not get the blood flow because I'm so vasoconstricted. Renin-angiotensin, which I talked about with the hypertension. Remember, if our cardiac output decreases, the perfusion to the kidneys decreases. When that occurs, renin gets released. When that renin gets released, remember the whole dating thing and the baby thing, angiotensin 1, angiotensin 2. And then angiotensin 2 is that potent vasoconstrictor, clamps down and says, I need to clamp down my vessels to help get blood flow to the rest of the body. And aldosterone gets released. And with aldosterone, we hold on to fluid and sodium, and there we go into fluid overload. Okay, so although the body's trying to help, sometimes it just spins out of control, and then we have more problems. BMP, or brain natriuretic peptide, gets released from the ventricle when the ventricle is overstretched in fluid volume overload. So who remembers, is this preload or is this afterload? Silence.
Afterload?
Nope. Remember, preload has to do with volume. I use that concept of balloon, and afterload is that straw. So afterload is the resistance that the heart has to get out, but preload is that amount of volume that's dumped into the heart. So when the heart senses that I have excess volume, stretched and stretched, BNP gets released from the walls of the ventricles to help the body naturally diurese. Hence why natriuretic peptide, that's what the title means, BNP. So that ventricle gets stretched and that BNP gets released. The more that it gets stretched and the more BNP gets released, the worse the heart failure is. Okay, so really paying attention to those levels is key. Remember what I said. We don't repeatedly draw BNPs. If we know they're in heart failure, we start all those interventions. It's if the patient gets worse and they're not getting better, do we need to draw another BNP to see if whatever we're doing isn't working out? And then myocardial hypertrophy, because the ventricle is like a muscle, it's building that muscle. Remember I said lifting weights, that ventricle gets enlarged because it's really trying to get that cardiac output out. See, all these can turn into a very bad situation. So very important. It's great initially, you or I, if we have, end up in fluid overload for some reason, we'll release the BNP, that'll help us diurese, we'll pee, and then we'll call it a day. But these patients sort of like cycle around negatively and not get out of that loop. This is directly from your book. I can't remember the page. No, I don't have the page number written on my handout. I love this slide. And I'm not going to ask you patho questions because this is not a patho class, but you're going to need to know the patho to understand why I'm giving what meds I'm giving. So if you look here in this dysfunction for whatever reason, and your cardiac output drops and your blood pressure drops, remember I talked about baroreceptors. They sense that there's a decrease in volume, decreased cardiac output, and the sympathetic nervous system gets activated, and catecholamines are in overdrive. Ding, 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 ding. And that's what I said. It clamps down and causes vasoconstriction. Okay. So it should increase your afterload, which would increase your blood pressure. And your heart rate goes up when you give epinephrine. I hope you know that. That's a side effect to epinephrine. Your heart rate goes up. When we have a decrease in cardiac output that leads to, because if I'm not pumping out of my heart, I'm not getting to my kidneys, I have this decreased perfusion to the kidneys. This is when renin-angiotensin gets activated. And we spent a lot of time on this on the last presentation. So you kind of probably, this is repetitive and I'm sorry, but it's so fascinating of how we can do this to compensate, but it also can spiral out of control and cause us to progressively get worse. So when we decrease the perfusion of kidneys, the renin gets released, angiotensin 1, we go to the lungs, we get angiotensin 2, goes over here and says, hello, let's release aldosterone, right? Let's do that potent vasoconstrictor 2, that angiotensin. Now we're causing vasoconstriction. The issue though is if I keep causing vasoconstriction, can I keep decreasing the perfusion to the kidneys? I hope you're all nodding yes. So do you see where this can spiral out of control? We want to block that conversion of 1 to 2 because we don't want that decreased perfusion. We already have an issue of perfusion to the kidneys, and now we're making it more difficult to perfuse the kidneys. So then you'll say, well, then I know exactly what I need to do in this patient. If I have a high afterload, don't I want to decrease the afterload? You say yes. If I have a high aldosterone and I hold on to water, don't I want to give medications that will help me get rid of that excess water? I hope you say yes. So that's where the diuretics come into play. The afterload reducers are where, like the Capidin that I talked about, or those Prills, help reduce that afterload so that heart doesn't have to work so hard to get that blood out. Okay, so that's what we're trying to do, is we're trying to prevent that hypertrophy. Look at that ventricle down at the bottom. It's like a, on steroids. So you can see that wall of that ventricle is hypertrophy because it's had to work so hard. We want to decrease the afterload so that the heart doesn't have to work so hard. And we want to decrease or block that conversion of 1 to 2. That's why you use ACE inhibitors. So we don't have that massive vasoconstriction and the heart doesn't have to work so hard to get that blood out. See how fascinating that is? And now you go, oh my God, now I know why I give the ACE inhibitor for a heart failure patient. I don't know if you're fascinated, but I am. Okay, so what do we need to do? We need to now start with that assessment or that noticing. And again, I said many conditions can lead to heart failure. You can go to that page and take a look at it. I'm not really stuck on that. I'm not going to say, please tell me 5 conditions that can cause heart failure. So take a look at that. You might have a patient that might have had one of those conditions. Most of the time in my ICU experience, I've seen people after significant MIs. I've seen heart failure progress from pulmonary issues. So that right-sided heart failure eventually progressed into left-sided heart failure. I've seen chronic kidney disease progress to heart failure. So those are the big guns that I would have to say that you probably would need to know. All right. I love this picture because I really think it does a great job of showing what the patient will look like. So impaired tissue perfusion, anaerobic metabolism. So if I have anaerobic metabolism, what level is up in my patient? What blood level?
Can you repeat that question one more time?
Yes, I can. If I have anaerobic metabolism going on, what blood value will be up in my patient?
Would it be CO2?
Nope. Anaerobic means without oxygen, right? So, Brianna, you got an idea?
I do, but I don't know if it's right.
Well, say it.
No, because she said the CO2, but you said no to it, and I was thinking of venous CO2, but
Nope, 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 and
No,
nope.
no, like the PaCO2.
Nope. Nope. That has to do with carbon dioxide, me not getting it off, blowing it off. Anaerobic metabolism. And I'm going to say,
They're H and H.
nope. Nope. So I'm going to say it ugly. I'm going to say it again.
I said, I forget. I know you just told us the other week.
I did. So I'm going to
BNP.
say it again.
BNP.
Nope. 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 I'm going to say 2 ugly words. And you're going to like twitch when I say them. Krebs cycle.
Ugh.
Okay. See what I'm
That
saying?
makes me think of chemistry.
Ah, say it again.
What did you say it was?
I said Krebs cycle. And what happens when I don't have oxygen? We produce lactic acid.
Yeah.
Don't forget that, because when we talk about shock next semester, that's the first lab value you need to look for. So when I'm not perfusing, and this is what I'm talking about, this is now a patient who's not perfusing the body. I'm not getting oxygen to the body. Now I have anaerobic metabolism and I'm building up lactic acid. Very important, okay? So we would look at lactic acid levels, but I want you to look at this patient. That if you think of on the left side has to get blood to the rest of the body. If you think of the left side has to get blood to the rest of the body, well, of course I'd be weak and dizzy, right? Because I'm not perfusing my brain. So do you think I'm going to be a little bit confused and a little bit like what's going on here? Pulmonary congestion because it's backing up into my lungs. Now, don't get stuck on that elevated pulmonary capillary wedge pressure. I'm going to teach you that next semester in critical care. So that's a pressure of how we measure on the left side of the heart preload. So it's elevated. They have excess volume on their left side of the heart. And if I have excess volume on the left side of my heart, it backs up into my lungs. So of course I'm going to be short of breath and have breathlessness. Oliguria, who knows what that means?
Excessive
Yeah,
urination.
Not excessive, nope.
No, it's decreased.
Painful urination. You're not
Yeah.
urinating.
Scant, don't say not urinating.
You're
So
not.
and this is gonna be important for next semester, so I want you to get this in your brain now. Oliguria is scant urine, so less than 400 milliliters a day. Anuria with an AN means less than 50 milliliters a day. So patients start saying, I'm not peeing as much. Anybody get any idea why I'm not peeing as much?
Kidneys aren't being perfused?
Exactly. So a lot of times when somebody comes in with like heart failure that's been a heart failure patient, I'm going to guarantee that they have elevated BUN and creatinine and a decreased GFR. I'm going to bet money on it. Because if I continually impair the perfusion to my kidneys, doesn't the kidneys get upset and their function decreases? So the BUN creatinine will be increased, GFR will be decreased, okay? S3 has to do with that excess volume. So you'll hear that Kentucky, 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 if you remember that from 110. They'll initially have a dry, non-productive cough, and then it could progress to pulmonary edema where they'll actually cough up pink frothy sputum. So initially they might be, you'll notice that your patient's coughing more, dry, non-productive cough. And it could progress to pulmonary edema. And then we've got a lot of problems there. Dyspnea on exertion, or DOE, is, they're fine sitting, but if you make them walk to the bathroom, they're really, really short of breath. Or if I have to pick something up and move it over here or whatever, they're short of breath on any type of exertion. And then orthopnea, I don't know if you have ever read, patient sleeps on 3 pillows. And you think, why are they asking? Orthopnea means I can't sleep laying down flat. I have to sleep upright. Okay. I have to sleep upright. So you do ask your patient, and you see how this guy's leaning forward. You see this guy leaning forward because he's having a really hard time breathing. And that pulmonary congestion, if you put a little arrow over to those crackles, and when I talk about crackles in heart failure, it's not just a few little ones in the bases because I'm not taking deep breath. You hear them all around, diffuse crackles, okay? Right-sided, take a look at her ankles. So this is the patient with those big tree trunk legs, pitting edema. When they sit up in the chair, you notice they're more swollen in the evening. And things are backing up from the right side. So if it's the veins can stretch. That's the beauty of veins. They're a capacitance. If you remember that from Claudia's lecture in 110, veins can stretch, so they can distend. That's why the veins in your neck distend. They can stretch with the excess volume. So neck vein distension, if you see bulging neck veins, you got to really suspect that this patient is in fluid volume overload. Increased abdominal girth, they could have ascites. And what could happen is, because I have excess fluid on board, that fluid can leak into my peritoneum. That fluid can leak, and I'm not a liver failure patient. I am a CHF right-sided, or not CHF, but heart failure patient. You will never do the hepatojugular reflex. The physician presses really hard down on the liver and sees this like up in the jugular. We don't do that. That's advanced practice, so don't worry about that. And then weight is the most reliable indicator. So I'll say to the patient, what do you normally weigh? And they go, oh, I weigh 120, and they come in at 150. They're up 30 pounds. They're up 30 pounds. So really telling your patient, you got to weigh yourself every day. And you got to call me. If you're up over 2 pounds, you got to call me. 5 pounds in a week, you got to call me. Really, really important you hit home with that. I cannot tell you how many times I've had patients come in 50 pounds up of fluid. I don't even know how they're walking around. So very important. See the difference. Now, can I have right and left-sided heart failure? Yes. Yes, I can. But if they're a bad COPD patient and, my left ventricle is still functioning okay, you might just see this picture. Do you guys see that? You might just see this picture of just right-sided heart failure. All right, so with the labs, let's talk a little bit about those. Because if I am left-sided heart failure and I have fluid volume excess, or even right-sided, let's just say either side, and I have fluid volume excess, would my electrolytes be dilute or concentrated?
Dilute.
Yes, yes. So you may see this heart failure patient come in with a sodium of 125. Now, I don't know if you had a panic attack about hearing that 125 or not, but you should. So when they come in, their electrolytes may be diluted out and be low. And it may not be that they're really low, it's because they have excess fluid. Same thing with the hemoglobin and hematocrit, and this is classic what I'll see. Somebody come in with fluid volume excess, severe heart failure, and their hemoglobin is 8 and their hematocrit is 28, okay? And then we diurese the crap out of them. We put them on a diuretic drip and their hemoglobin goes up to 12. Now, did I give them blood? No, I took the excess fluid volume off and that hemoglobin 12 is probably what they normally are. Please, please, please pay attention to the patient's fluid volume status when you're looking at electrolytes and your hemoglobin and all those things. Because if I'm in fluid volume excess, they're going to be hemodiluted. Okay, you'll see a change. You'll definitely see a change. The BNP, if I'm under 75, we want it less than 125. If I'm greater than 75, we want it less than 450. The higher the BNP, the worse the left ventricular function. Highest BNP that I saw was 80,000. I'll say that one more time, 80,000. And I went, oh, that's the highest that I've seen. So really important that you pay attention to that. That, again, we're not going to do repeat BNP levels unless I don't see a change in the patient's status. Very, very diagnostic. You come in with shortness of breath and they suspect you're a heart failure patient. This is the first, it's a blood test. Very simple. We could draw this blood test and we could take a look at it and we can absolutely say for what certain or not, whether it's heart failure or not. A little caveat, the BNP could be slightly elevated in chronic kidney disease as well. But I am not talking 80,000. I'm not even talking 1,000. I'm talking, it might be 450, 500. Do you guys see that? A very slight elevation. So just so you know that. And again, we're going to use our physical findings as well to sort of help support that BNP level. Urinalysis, a high specific gravity is back to that oliguric patient, and I'm not making as much urine. So I have a little bit more concentrated urine. I'm holding on to the volume and recirculating it. So your specific gravity would be greater than what?
1.030.
That's exactly right, Carly. 1.030. Because a normal is dimes to quarters, we used to say. So 1.010 to 1.030. 25, depends on what book you read. And so if we have a high specific gravity, that tells me my urine is very, very concentrated. Okay. And you say, well, they look fluid overload. It's because they're not making urine because they're not perfusing their kidney and they're dropping in the urine output and the kidney function. So do you see how closely related heart failure and kidney disease are? You got to pay attention to that. ABGs, if you want to take a look at those, really with the ABGs, maybe they're hypoxic. So you'd see the PO2 level, if they're hypoxic. If they're a significant COPD patient, or if they're in significant pulmonary edema, let's go with that, because I have significant, remember I talked about the backflow and the pulmonary congestion. I can actually be in pulmonary edema, and now I don't have gas exchange. So what would go up? PCO2, right? So this patient may look like respiratory acidosis. This patient may look like respiratory acidosis. Okay. All right, I think that's it for this slide. Take a look at this chest x-ray. It should be black all the way down here. I call this schmutz. You know, this should not be like that. It should be like this up here. Because air, if the lungs were filled with air, it would be black. So is there fluid there? So that's that congestion. The dilated vessels, and again, no one's going to ask you to like diagnose that. That's your radiologist. Dilated vessels could be due to valvular disease. Like if I have significant aortic valve disease, that aorta can be enlarged, okay? Because there's a lot of pressure in that aorta. The other thing, do you see this heart, how large it is? I'm going to draw, I'm going to take my air. See how it's all the way over here? This is cardiomegaly. So you circle that. Look how large that heart is, okay? So if we see a hypertrophic or that cardiomegaly, that's chronic. Like we don't just become cardiomegaly overnight, okay? We don't become cardiomegaly overnight. So that's somebody that has had some chronic episodes. Liver congestion, because remember, everything backs up. So the liver, it's got this blood that it wants to get out, but it can't. So you might see that the liver is like engorged with more blood, maybe on a CAT scan. Okay, echo, remember I said it should be 55 to 65. Less than 40 systolic dysfunction, because now we can't contract and eject that blood out. Greater than 40 could be valvular disease or diastolic dysfunction. I am not going to ask you to please tell me if less than 40 is diastolic, and that's for the cardiologist. I'm just giving you a heads up that if you see an EF of 10, you're like, oh my God, that's got to be severe systolic dysfunction. EKG, we're going to look for arrhythmias. Now, do you think, let me ask you this. Do you think an arrhythmia, and that's a rhythm issue, or a rate issue could cause me to go into heart failure?
Yes.
Which ones do you think is the most common one that we see?
Rate,
Say it again.
rate.
Well,
AFib?
yes,
AFib.
AFib. Here's why I want to talk about that. So in AFib, these atria are fibrillating up to like 300 times a minute. They're going crazy. And there's no way that I can inject this blood out, right? It's just because I'm not contracting, it's going to back up. So definitely rate's an issue too. If I'm pumping at 200 an hour, I'm not getting a cardiac output, am I? I'm not getting where the heart can fill up appropriately. You need appropriate fill time. So definitely rate and rhythm could do it. I see AFib with a rapid ventricular rate is one of the most common ones. AFib with a rapid ventricular rate. And that means that because the AFib are fibrillating, or the atria are fibrillating, these ventricles are going, I need to catch up, I need to catch up. So the ventricles start speeding up. So they're in atrial fib, but their rate's like 150. Bad scene. We need to slow down that rate, and we need to get that rhythm under control. So definitely looking at their EKG or their rhythm strips is going to be very, very helpful. And remember, we talked about that ventricular hypertrophy also on the EKG. We talked about that somebody with that chronic hypertension, with that chronic high afterload is definitely going to make an issue for that patient. So the EKG can tell us the left ventricular hypertrophy as well. And then last is that pulmonary catheter. And I want you to sort of pause on that. We're going to talk about that next semester and how we monitor all of those pressures within the heart. We would get some specific numbers. So we're going to talk about hemodynamic monitoring that tells me really what's going on with the patient. Pulmonary artery catheter, although very invasive, is beautifully diagnostic. It tells us a lot of what's going on inside the heart. It can tell us filling, it can tell us contraction, it can tell us a lot of things that we'll talk about next semester. So don't focus too much on the pulmonary artery catheter yet. Okay, priority collaborative problems. So these are your AKA nursing diagnoses, but now we're using it as collaborative problems. We definitely have an issue with gas exchange because if my alveoli are filled with fluid, because I'm in fluid overload, can I exchange O2 and CO2? No, no. So that gas exchange is 100% affected. Okay. Patients come in, they're short of breath, back to that guy that's sitting up and leaning forward and having that breathlessness. So we need to unload the volume in the lungs. We need to unload that volume in the lungs. Potential for decreased perfusion, 100%. If my cardiac output is not effective, we're not going to perfuse the kidneys. We're not going to perfuse the brain. We're not going to perfuse the liver. All of those beautifully important organs we may not perfuse because I'm not getting the cardiac output. Fatigue and weakness, and then absolutely potential for pulmonary edema. I'm having shortness of breath, and we have progressed now to full-blown pulmonary edema, which is a medical emergency. Pulmonary edema is a medical emergency. Okay, they're really short of breath, they're hypoxic. They may most likely end up in the ICU unless you fix them very quickly in the emergency room. So what do I want to happen? And again, this is very general, increasing gas exchange. So to make that measurable, I'd say I want the pH to be between 7.35 and 7.45. Improving cardiac output, I want the cardiac output to be between 4 and 8 liters. We're going to teach you that next semester. Decreasing fatigue, as the patient able to walk 50 feet, you know, today and tomorrow we'll increase that to 75 feet. And then preventing pulmonary edema, you know, listening to the lungs and making sure that they're taking their medications appropriately and they're not cheating with their fluid restriction. All right, so how do we improve their gas exchange? So ventilation assistant can be a couple of ways. The guy to the right that you see up there is a BiPAP machine, B-I capital P-A-P. And it's bi-level. So there's an inspiratory pressure and an expiratory pressure. And I'm sure Stephanie talked about this with COPD patient. But BiPAP, it's called BiPAP because it's bi-level. So we have an inspiratory pressure and an expiratory pressure. So it's going to help ventilate the patient without putting a breathing tube down. So it's a non-invasive way to ventilate a patient. BiPAP is a non-invasive way to ventilate a patient. You're going to monitor the respiratory rate every 1 to 4 hours, depending on where you're at. In the ICU, we do it every hour. Maybe on an intermediate, you do it every 4 hours. You're going to listen to breath sounds. In the ICU, we do it every 2 hours. Could be every 4, it could be every 8. So depending on where you're at, that's why you make your care plan very, very specific. You're going to put them in high Fowlers if they're dyspneic. Sit them up, you guys. And that's one of the first things that you can do. Okay, sit them up. Reposition the patient, help sort of mobilize those secretions. They'll probably want to have a tendency to not move at all. Get them moving. Get them moving. Coughing and deep breathing and chest PT. That's chest physiotherapy right there. You remember the cupping? If you remember that way back, that's chest physiotherapy. We're trying to mobilize secretions. And then maintain the oxygen sat of 90. Why did I pick 90? Anybody got any ideas?
Because they're used to being on with like low oxygen saturation.
So if I'm a COPD, and Lisa, you bring up a good point. If I'm a COPD patient, 90 is acceptable for them. One pulmonologist told me that he walks around Walmart and he's 77. I'm like, oh my God. So 90 is acceptable. We don't want a COPD patient that high. But even in like when COVID came about and I had people with no prior lung disease, I was doing cartwheels when they were 90. So 90, I mean, if you're greater, yay for you, but really 90 is acceptable. Okay. And some physicians will say if they're like chronic COPDers, if they're 88, I'm okay with it. And you're like, so always ask that question. Always ask that question. COPD patients, if you remember what Stephanie taught, drive on that they breathe on that hypoxic drive. You provide a COPD patient too much oxygen, you'll knock out their thrive to breathe. They'll stop breathing. So really important that you pay attention to that. Improving cardiac output. You want to think about these three concepts. So this is why I started with this a couple lectures ago. Preload. Preload is the balloon. So how much volume does this patient have? Do they have excess volume? So we want to reduce that volume. Preload is the amount of volume in the heart. So on the right side of the heart, we call that the central venous pressure, or CVP. I'm sure you've heard of that, or right atrial pressure. On the left side of the heart, we call that pulmonary capillary wedge pressure. That tells me, and I can measure those with that pulmonary catheter, I can measure the preload. CVP on the right, pulmonary wedge pressure over here on the left. That tells me if my CVP or my wedge pressure is high, I have excess volume. Okay. And in heart failure patients, they have excess volume. We want to bring that down. Afterload is the amount of resistance the heart has to pump against to get the blood out of the heart. That is your SVR. We talked about that before. So your SVR on your left side of your heart. You have SVR on the left side of the heart. On the right side of the heart, we have something called the PVR, or the pulmonary vascular resistance. And that's your COPD patients. They have high afterload on the right side of the heart. Okay. People with really bad high blood pressures have high afterloads on the left side of the heart. So patients with hypertension have high afterloads. Hence why we give Capita or the Prills or the ARBs to decrease the afterload in these patients. Anybody know what drug helps me contract more effectively? So if I have really crappy ejection fraction, let's say 40%, what drug will I give to help me contract stronger?
Is it digoxin?
Yes, DIG, because DIG is a positive inotrope. Positive inotrope. And what that means is it helps contract stronger. So when we look on echo and we see them contract like this really weakly, we add digoxin to help squeeze better, because the better that we squeeze, the better the cardiac output. Okay, so we have drugs that affect the preload, we have drugs that will decrease the afterload, and we have drugs that increase the contractility. So you got to know where my problem is. Do I have too much fluid, too much resistance, or a crappy pump? Does that make sense? So then you understand why we're giving the drugs that we are, because of whatever the problem the patient has. So here's drugs to reduce afterload. Well, look at that. Didn't we just talk about ACE inhibitors? First line therapy in heart failure. And the reason why is ACE inhibitors not only decrease afterload, but they decrease preload. So instead of having to take 2 drugs, I can take 1. So ACE inhibitors, they're the gold standard, unless I can't take them, to decrease afterload and preload. Beautiful drug. Pain in the butt, causes the cough, can make their potassium levels go up, those kind of things, but it is the first line therapy. Okay. If I don't tolerate the ACE inhibitor, I can go to an ARB. Okay. I can go to an ARB because maybe that cough isn't there like with the ACE inhibitor. So with the sartans, think of the sartans. The one I did not talk about in the hypertension lecture is this Entresto. And if any of you guys watch Hallmark, the sun will come out. That's the commercial, and it's about Entresto. It has an ARB in it, but it also has this receptor inhibitor. And this is now the drug that people are wanting to get. It's the new guy on the scene. This Entresto is a combination drug that they're seeing better outcomes in patients with heart failure. And then this Natracor down there, this human BNP, we can give that in the ICU via IV. We can give that via IV. This is a really, really sick heart failure patient, probably in the ICU. Okay, so that's why I have a sun there. If you haven't put the connection there, if you haven't seen the commercial, but it reduces the blood pressure. And then look at this, the neurohormonal and renin-angiotensin effects of heart failure. So we go back to that patho. It stops that crazy baroreceptors and the sympathetic nervous system. And now it stops that renin-angiotensin effects as well. Significant reduction in hospitalization and death rates from heart failure. So this Entresto's, and I've only maybe taken care of a handful of patients on Entresto. I don't know if it's quite expensive because it's a new, it's probably, hasn't had a patent yet on it, or, the patent hasn't ran out to go to generic. So I'm sure it's quite expensive. Let's do a couple more drugs and then we'll take a break. Interventions that reduce preload. So here's the volume situation. Like, let's think about the volume. Remember what I said, the sodium restriction, and we talked about in the hypertensive patient of that 2.4 grams. I need you to understand in a heart failure patient, it's probably even less than that. It's probably going to be a 1 gram. It might be a 1.5 gram. It might even be as low as 500 milligrams. No one is ever going to ask you on a NCLEX test, how much sodium should your patient get? That's up to the cardiologist or the nephrologist that is taking care of the patient. You are responsible for executing and carrying out whatever that sodium restriction and fluid restriction is. Fluid restriction can be 1 liter a day. It could be 1.5 liters a day. Again, no one's going to ask you to figure that out or calculate that. That's the provider's decision. Most frequently, I see about 1 liter a day. You'll also see the cups that have lines on it in patients' rooms, because patients don't realize, oh, that was 200 mLs of water that I just chugged down. So they'll give them a measured cup so they know exactly how much fluid that they're taking. This is where they get in trouble because they don't pay attention and they overdo the fluids and they come back into the hospital because of excess fluid. Absolutely weigh your patient every day. And remember, if I'm up 2 pounds within a day or 5 pounds within a week, they need to call the provider because he may order a different type of sodium restriction, or he may give an extra dose of diuretic. They must weigh themselves daily. We don't wait till a week goes by and then we've got trouble. One of the things is our CHF educator at the hospital actually got a grant to give patients a digital scale to go home with, because patients, some don't have scales. So when she is educating them, she will bring in a digital scale for them so that they can weigh themselves every day. Very, very important. Those weights should be done before your provider comes in, so he can make a judgment of whether he wants to continue the diuretics, increase the diuretics, or stop the diuretics. Okay. Loops, I want to say that you can give IV push, intermittent push, or you could do a continuous drip, Bumex drip, a Lasix drip. Depends on the physician. No one's going to tell you which one's better than the other. The renal group that I work with likes Bumex drips. You might go somewhere else where somebody likes Lasix drips. That's a continuous drip. They are that fluid overloaded. Some patients, twice a day diuretics, maybe 8 in the morning, 4 p.m. Some might start on IV push and then be transitioned to oral because you got to go home on oral. So again, not for you to decide, for you to give safely. So what do I need to worry about before giving this loop diuretic?
Potassium.
Okay, what else?
Fluid balance.
Oh.
Electrolyte,
Okay. What else?
kidney output.
So
BP.
BUN, creatinine, GFR. I am telling you, that is one thing that they'll look at, because I can over diurese, can't I? I can give
Mhm.
diuretic and I can dry up them to like a rock. So very, very important that you're paying attention to all those. Now I'm gonna even do another trick question. What lab value will go up because I'm losing potassium and change my acid base balance?
pH.
Okay, but why? Okay,
Because you're losing the hydrogen ions too.
so we're, okay, so what lab value is gonna be high then?
Semi bicarb.
Venous CO2 or the
Okay.
bicarb, 100%. Pay attention to anybody that's on a diuretic to the venous CO2. Very good. Pay attention to that, because we can over diurese somebody. Drugs are great. We can undertreat, we can treat, or we can overtreat. It's our job to really pay attention to what's going on with that patient. So they might have had a venous CO2 when we started this of 28, and now they're up to 38. They're really, really metabolically alkalotic now. This has nothing to do with the lungs. This has to do with their, just like Elise said, we've lost all these H ions, and now we're really alkalotic because you gave too much diuretic. Pay attention to that. You may see them on potassium sparing, so aldactone, very common, so that they don't have to chase the potassium so much. With like the loop diuretics, we're constantly treating with potassium. The problem with potassium sparing is what though? What happens to my potassium?
Goes up.
Yes, 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 yes. So you still got to watch the potassium. Do you guys see that? So, you know, you might be really giving them a lot of aldactone and you're like, oh my God, their K keeps going up, 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 up. Pay attention to that. Same thing with the BUN and creatinine and GFR, and the same thing with the venous CO2. Okay, pay attention to that. All right, venous vasodilation. So that means on the venous side, we want to dilate the venous side so we decrease the amount of preload that's dumped back to the heart. If we dilate the veins, we decrease the amount of blood flow back to the heart. So we decrease preload, okay? So Iserdil, which is a nitrate, great drug, but it only does the venous side, a little bit of the afterload side. Remember with heart failure, I have an afterload and a preload problem. That's why the ACE inhibitor works so great. Now we've got to do two drugs. So we do the Iserdil for the preload, and then we're going to give, do you remember hydralazine, what I talked about for hypertension? Hydralazine or apresilene, hydralazine, that's a combo drug. Hydralazine is a beautiful afterload reducer. So I'll give hydralazine IV in the ICU to help bring down the blood pressure. So because Iserdil by itself doesn't really help with the afterload, now we can give Bidil, which is a combination drug that'll help with preload and afterload. And why do you think I have that there? Anybody? You're like, hell, I don't know. You just want me to learn something new. The African American population doesn't do as well with ACE inhibitors. And they would have to, not everybody, because you're going to come to me and say, I took care of a patient last week that was on an ACE inhibitor. Some do okay, but they had found that as a group, the African American population didn't do as well with ACE inhibitors. They had to take two drugs. Now they've combined them with the hydralazine and the Iserdil into Bidil, which now helps us with more compliance because now it's one pill. If I just give the Iserdil alone, it's vasodilator. Nitrates, think of decreased preload. Can a nitrate decrease the afterload a little bit, but that's not what it's used for in heart failure. Contractility, and then we're going to take a break. So you guys did say with me about digoxin, and I want to talk about that in a minute. This Natracor or Primacor, Milrinone, IV continuous drips more often than not in the ICU. Let me say that one more time. More often than not in the ICU. Now, years ago, when people were in acute heart failure and they came to the ICU, we put them on this Dobutrex, okay? And Dobutrex, again, positive inotrope, but I've seen a lot more Milrinone being used than Dobutrex. They all help with contractility to help that heart contract better. It's a positive inotrope. So it affects the strength of the contraction of the heart. Dig, I want to talk about Dig. I can give it IV push, cannot give it in a continuous drip, cannot. So I can give it IV push, I can give it orally. So it might be a great, because these Primacor, Natracor, and Dobutrex are IV. I'm not going home on that. But here's the problem with digoxin. If I'm in an acute situation, it takes time for me to build up a level. So I'm going to have to load the patient up on IV every 6 hours, 4 doses, and then I can transition them. Anybody know what a normal dig level is? If you don't, you better. Silence.
Isn't
Is
it
it
like
0?
1 to 2.5?
Close.
I don't know.
Who else?
0.8 2.0.
Yep, 0.8 to 2. The thing with Lanoxin, patients can become toxic quickly. So you really got to pay attention to those dig levels. You hear people say, oh, let's get a dig level. You really, and especially, I want to say this one more time, especially people with decreased kidney function. I can't excrete. I'm going to have an increased chance of toxicity. So your brain says somebody coming in on dig or digoxin, you say, where's my level? And if they don't have one, you play dumb like I do and go to the doctor. You're like, do you think you need the level? I play dumb all the time. Somebody have a question? Nope. So I play dumb all the time and say, hello, do you think we need a level? And they go, oh, that's a great idea. And they think that they thought of it, but pay attention because there's a lot of side effects to digoxin. The biggest one, anybody know parameters, what I should do?
It drops your heart rate.
Yeah, so when should I hold it, Brianna?
Oh, less than 60. If
You
it's less.
got it. You got it. So again, this is a drug that I'm not going to give if I don't know the heart rate. And I don't care what the heart rate was at 7 a.m. I need to know the heart rate at the time that I'm giving the med. That's exactly right. So pay close attention. You better document on your MAR what their heart rate was when you gave that medication. Because if you go to court and you say, well, the heart rate went to 20, well, it was 40 when you gave it. Well, that was just stupid. That's going to be negligence. But if you say it was 120 when I gave it, there's no reason not to give it. Does that make sense? So please, please, please make sure you document what that heart rate is. Beta blockers should not be started in acute heart failure. So somebody coming in acute shortness of breath, we got to get them out of that heart failure. We're not going to stop it because it could affect the contractility and sort of decrease that cardiac output. So that's not something we would start right away. Aldactone, and you can see if they've got a really crappy EF, that's I see more often than not putting them in aldactone for the diuretic as well. Okay. And then this last one, I've not really given this drug, that Corlanor. I've not given it, and maybe in Cleveland Clinic they have, but you can see for heart failure, EF less than 35 and heart rate has to be greater than 70. Okay, because it can decrease their heart rate. So if they don't have a heart rate greater than 70, you are not to start this medication. If they don't have a heart rate greater than 70, you are not to start this medication. it can slow them down. Okay. All right, it's 6:50. How about we come back at 7? We'll take a break. Let me hit pause. And we'll start back up at 7. So get yourself something to drink, go to the bathroom, whatever you need to do.
Dr. Comer, can you say that real quick one more time about the heart rate? If
Mhm.
it's not greater than 70, don't give it.
Correct, because the side effect to this drug is to slow the heart rate down. So if I'm already slow, 60, now I'm going to make them 40, 50, 30. Do you see what I'm saying?
Yeah.
So the parameter is they have to have a heart rate greater than 70. I've not given this in the ICU here, and it could just be, I don't know, maybe our cardiologists don't use it, but it is out there. So I just want you guys to know about that.
Thank you.
You're welcome. All right, take a break, everybody.
There you go.
One.
Audra, you're unmuted.
Back up 27. So behind the base. Nice.
Audra, you need to mute.
Come on, Riley, take it yourself. All righty, are we back?
Yes.
Oh, well, hope you weren't swearing on that break because I forgot to hit pause recording. All right. So let's go back. And we were finishing up. Sorry, I'm going the wrong direction. All right. So we had finished up contractility drugs. Let's talk about this Natracor. So what's important about this is you're not going to see this in a general floor or intermediate. You're going to see this in the ICU. So what does it do? It causes diuresis. So we're going to lose, and natriuresis, we're going to lose sodium. With sodium, we lose water. It's going to help vasodilate. This is used in acute, not cute, pretty, but acute decompensated heart failure with dyspnea at rest. So they use this in acute decompensated heart failure with dyspnea at rest. So I'm just laying in the bed and I'm short of breath and I'm having a hard time. You're going to get started on this. Told you about the ICU. Often in combination with other drugs. It can cause hypotension. Think about we're losing volume. Can cause dysrhythmia, so you're going to have them on a monitor. Headache, abdominal pain, and insomnia. Cardiac glycosides, we talked about DIG. And what I want you to know is underline that, star that, it's not first line treatment. Remember I said you have to load them up. You have to give them 4 doses over a period of 24 hours IV just to get them loaded up. I'm not going to ask you that as a test question. I'm just telling you that's how it is. And it takes a while to get them therapeutic. So it's, again, not first line treatment. Okay. It controls the rate and it helps convert. It helps, not all patients do, but it can help convert that atrial fib back into a sinus rhythm as well. It can help with that arrhythmia of atrial fibrillation as well. So you could see if somebody has AFib with a rapid ventricular rate that ends up in heart failure, it's a good drug because it can help with contractility as well as controlling that rate and converting them back to sinus rhythm. So it decreases the rate of electrical conduction. So back to that AFib with rapid ventricular rate, slows down that heart rate. And then it prolongs that refractory period. So now we can try to convert ourselves back to sinus rhythm. Okay. Positive inotrope, so this is going to help with contraction. Make that connection, contraction, inotrope. Negative chronotrope, so when we talk about chronotrope, that affects the rate. So if we have a drug that's a negative chronotrope, that decreases the heart rate. Different concept. And then negative dromotropic, it decreases the AV node conduction, and it'll help with that conversion of that AFib into sinus rhythm as well. Adverse effects. So, and here I have the level right there. Very narrow therapeutic window. And what that means is the potential to become subtherapeutic or over supra therapeutic or toxic is very easy, because you can see it's 0.8 to 2. There's not a lot of wiggle room within that lab value. So it's really important that you keep a close eye on that. If a patient has a low potassium level, because they're on Bumex as well as being on digoxin, which is very common, you could become more dig toxic because of the low potassium levels. So your brain says, before I give Lanoxin, I'm going to check my patient's potassium level. And if it's low, we're going to end up treating it. And when we go to CVIC next semester, there are some standing orders on treating potassium levels. So we don't even have to call. We could just take a look at what that standing order is. So make sure that if you're getting ready to give digoxin, that you know what their potassium level is. Definitely need to know the electrolyte levels, particularly the potassium. BUN, creatinine, and GFR, remember what I said, the patient can potentially become more toxic if the kidney function is not good. So really paying attention to what the BUN, creatinine, and GFR, so important. What kind of side effects? The big thing that I worry about is patients when they have too much dig going on, they become really bradycardic, and they'll come in and their heart rate will be in the 30s. I've seen it more on the slower side than the high side, but it can become tachycardia as well. You can see some neurological, I mean, every drug causes headache, fatigue, malaise. The big thing with this one is the colored vision. They see yellow or green. I've never heard purple, more yellow, green, and halos. So they see like lights around their vision. So halo vision. So, you know, if the patient says, oh my God, there's like a light around your head, that's what they're talking about. And then flickering lights. Now, in the case of dig toxicity, anorexia, nausea, vomiting, and diarrhea are all really important, because that is a sign of dig toxicity. So I know I've said that most drugs can cause nausea and diarrhea, but in this case, if they're on dig, you really want to pay attention that if you notice they're starting to throw up and continually nauseated, start to suspect that your patient is dig toxic. I already said condition, the potassium level can predispose dig toxicity, liver dysfunction, high calcium levels, dysrhythmias, hypothyroid, respiratory, renal disease. So pretty much anything, just again, and I'm not going to ask you this list, but really pay attention to what the dig level is. Your brain should say, this guy's got multiple problems. They've got kidney disease and heart failure, and I should be paying attention to what that dig level is. If a patient, for some reason, overdoses or they're severely dig toxic, we're going to give this drug called Digibind. So your brain says, oh, I think it just binds with the digoxin. And it's going to help with getting rid of and decreasing that dig toxicity. So I've never, in my 32 years, think I've ever given Digibind. But if somebody, and I guess if you took an overdose, and I've never had anybody overdose on digoxin, so perhaps I'm sure there's people who have, I've just never taken care of a digoxin overdose. Stroke volume is the exact amount of blood that gets ejected on each beat. Okay, so stroke volume is the amount of blood that gets ejected on each beat. It's not a percentage like your ejection fraction. It'll help decrease the heart size during diastole, so that's a good thing. Decrease venous BP and vein engorgement.
I'm sorry, Mrs. Colmer, can you please repeat what you said about the stroke volume? My computer kind of cut
The
out.
stroke volume is the amount of blood that gets ejected with each beat. So every beat, we have a stroke volume of 56. So that's 56 mLs with each beat. That's what a stroke volume is. All right. Helps with coronary circulation, decrease in exertional and paroxysmal PND. I know you probably read it in the chart. That's what they're talking about. And what PND is, I'm dead asleep, minding my own business, and I wake up short of breath. So paroxysmal nocturnal dyspnea, I become short of breath in the middle of my sleep, wakes me up. That's what PND is. Paroxysmal nocturnal dyspnea. Out of dead sleep, I'm short of breath. There could cause cough and cyanosis, or decrease cough and cyanosis. And the reason why the cough and cyanosis decrease is we're getting a better cardiac output because the heart's pumping stronger and the blood's not backing up and causing me to have congestion within the lungs. And the cyanosis, because I have better gas exchange, because my heart's pumping better, I'm getting a better cardiac output. I'm not as hypoxic. There's less cyanosis. Increase in quality of life, yes. And then no apparent reduction in mortality. So mortality has to do with death. And I still see some people using DIG, but not as much because it's really, really an old drug. But for some reason, NCLEX still likes to use DIG. Your milrinone, again, this is going to be in the ICU. And it's a positive inotrope, so it's going to help that heart contract better. And it's also going to help with that SVR, or that afterload, that vasodilatation. So it's going to help open those. So there's less resistance for the heart to have to pump against. And increase calcium for contraction. So we need calcium for muscle contraction. It's going to help increase that contraction because your heart is a muscle. I do see more Primacor or milrinone nowadays, especially in the ICU. You can see short-term management for heart failure, and it's against the American Heart Association, ACC, for long-term infusion. So short-term to get them through an acute episode of heart failure. So short-term use, let's get them on something because they can't go home on this. So short-term use. Decompensated heart failure, let's get them stabilized and get them on something that they can go home on. Only injectable, I told you IV. And you can see can cause dysrhythmias, it can drop your platelets, your liver enzymes. So your brain says, I'm going to watch them on the monitor, I'm going to get my electrolytes, I'm going to see what my CBC and my platelets look like, and I'm definitely going to look for an AST and an ALT because those are the side effects. So you want to make sure that it's not causing all of these to occur. Interactions, yes, it already causes hypotension. So now we're adding a diuretic. It could really make the patient hypotensive. And now we have a whole nother problem. So you definitely want to pay attention to their vital signs. And then if I have DIG with this, it's going to be too much contractility. So then now we're really overworking the heart. So you want that sweet spot. You don't want to have too much and you don't want to have too little. So heart failure drugs, nursing implications. We need to assess history, drug allergies, and contraindications. We want to definitely take the blood pressure and the apical. I didn't say the radial. Apical pulse for 1 minute, 1 full minute, because if it's a dysrhythmia, you're not going to pick it up maybe in that 30 seconds that you're taking the pulse. So you want to take a listen to the apical pulse for 1 full minute. You're listening for heart sounds S1, S2, but do we have S3 and S4? What do the breath sounds sound like? Do we have diffuse crackles all the way up to the apex of the lungs? So really paying attention to any change. And it was interesting, and I think I shared with you with my friend that came in with kidney disease, kidney failure. I took a listen to her lungs and she had crackles about midway up in her posterior chest. And I said, she's not short of breath, she's not on oxygen. And I went back to the nephrologist and I said, I don't know, do you think we should just get a BNP? And she was in heart failure, not on any oxygen, She said she didn't feel short of breath. She had crackles halfway up the back of her lungs. She's she's 65, so that's young. She's young. She has no prior cardiac history, nothing. So, and it was just on a whim. I said, don't you think we should get a BNP? And it came back positive. You're going to weigh them daily, no matter what. Even if you don't have an order, you weigh them daily. Intake and output, strict. And nothing drives me more crazy when I work for this renal group when there's no intake and output measured and I'm giving a ton of diuretics. And then I'm like, well, I don't even know how this patient responded to the medication because nobody bothered to measure the urine. And when we order strict INOs, that means you get a hat in there and you tell the patient to pee in the hat or a urinal or whatever. We need to know the response to the diuretic. Why would I keep giving something if they don't make urine from it? Or why, if they've made 5,000 milliliters, I've given too much. So it's really important that if you have been ordered strict INO, that you make sure that you are monitoring what goes in and what comes out. Okay, electrocardiogram. Definitely want to take a look at that so that.
Something I found on the web.
Oh,
According to Purdue.com.
sorry guys, my Alexa just started talking to me. That was
Here's
weird.
something I found on the web.
Alexa, stop. That was weird. Okay, so electrocardiogram or 2D echo. We want to look at the ejection fraction, look at that valvular function, and then absolutely your electrolytes, particularly if I'm on diuretics, what are we going to add? What lab value?
Potassium.
Potassium.
Oh, it's already there. Add to this bunch.
Venous CO2.
Thank you, thank you, thank you, thank you, thank you, thank you. Because I can excessively overdiurese and spill a lot of potassium and lose H ions in my urine, and I can make the patient severely metabolically alkalotic. So add venous CO2 to that. You're not leaving the school without knowing what the venous CO2 is. All right, so before giving any drug, we want to check the pulse for 1 full minute. And if it's less than 60, now here's what I want to tell you. Some providers are braver than others, and some will say, wait till it's 50. If it's a written order, you're covered. You are covered. So if they don't write a hold, go with what's in the book, 60 or greater than 100. But some physicians will be like, if it's 55 or greater, give it. So pay attention to what they write in their order. It's up to them. They can make the decision that their patient can have a little bit of a lower heart rate. However, whatever that parameter is, and more often than not, it's 60, you're going to hold it and you've got to call the prescriber. If you hold it and don't call him, he doesn't know that you've held it. He thinks the patient's still getting it. So take that extra step to notify the prescriber that you had to hold it because her heart rate was 42. Okay. Absolutely hold the dose if they've got, they start vomiting or diarrhea, or they're saying that their vision's changed and that they notice those halos around, because now we are starting to think they're toxic. And ask for a DIG level. Ask them, hey, what do you think about getting a DIG level? Check dosage forms carefully and follow instructions when administering, depending on if it's IV push, continuous IV, or oral. Avoid giving DIG with high fiber foods. It binds with the digitalis and it'll be harder to get the patient therapeutic. It'll be harder for the patient to get therapeutic. So you don't want them to eat a loaf of bread with extra fiber while they're taking their DIG in the morning, maybe later in the day. So avoid giving it with high fiber foods. Patients should circle this. I can't stress this enough. Of a weight gain of 2 pounds or more in 1 day, or 5 pounds or more in 1 week. They should not come in 30 pounds up. They should not come in, excessively fluid overload. Way more complications. So we want to nip it in the bud and get it right then and there early. So how do we treat? I like pictures. That's me. I'm simple. Put them in an upright. So that's your high Fowlers. Your nitrates. Remember what I said, that Isodil, that nitrates or nitroglycerin decreases the venous side, venous preload, the venous return, or the preload to the heart. So it decreases the preload to the heart. Lasix, of course, diuretic. Oxygen, because they're hypoxic. ACE inhibitors, remember, decrease preload and afterload if they can tolerate it. If they can tolerate it. Digoxin, especially if I have a rapid rate or if I'm in AFib or I have an issue with contractility. We're going to start some digoxin. If they're on fluids, I hope you have a conversation with the physician to have them stop the IV fluids. Or what kind of restriction do you want this patient to have? A ton of education with the patients, because it would be a big challenge for me to decrease my fluids if I end up in heart failure. I'm going to be really mad if I end up in heart failure because I drink probably 3 liters of fluid a day. So for me to be on a 1 liter fluid restriction would be quite a challenge. Afterload, we want to give those drugs. And if you give an ACE, so you can put that up there too, because ACE does afterload and preload. But if I don't tolerate an ACE, I can do something like hydralazine. There's other drugs that reduce afterload. That's that resistance, whatever the patient may tolerate. And then sodium restriction absolutely could be anywhere from 1 gram, 2 grams to 500 milligrams, just depending on how severe the patient is. And then if you look at the bottom, DIG level, ABGs, and a potassium level. I want you also to put BUN, creatinine, and GFR for that one as well. Okay. Why don't we, what time is it? Why don't we stop there and let's do the heart failure case study. Silence. Hello?
Yes.
Okay, you there? Okay. Thank you. For
You're
All
welcome.
right. So thank you so kindly. So this little lady, you have this little lady?
Mhm.
Okay. All right. So let's talk about this little lady. She's 72 years old. She had an MI 4 years ago. Systolic heart failure secondary to ischemic cardiomyopathy. So what that means is I have lack of blood flow to the heart, and it's causing cardiomyopathy, damage to the heart. And my ejection, is 15. So you guys highlighting that, circling that, starring that. Her ejection fraction is only 15. She's in a bad way, isn't she? Are you guys getting that vibe yet? Okay. She presents to the ED with shortness of breath. Her shortness of breath has progressed from shortness of breath with activity to shortness of breath at rest. Okay. Last 2 nights, she slept in her recliner. Huh? Is that like your pillows?
Mhm.
Okay. So she slept in her recliner, and I cannot tell you how many patients I actually have interacted with that actually sleep in a recliner because they can't lay down. Okay. She's able to speak only in partial sentences and has to take a breath when talking to the nurse. Increased swelling in her lower legs. 6 pounds in 3 days. She's being transferred to ED, cardiac step down. Well, you're the nurse taking care of her. She's a retired math teacher who's unable to maintain her level of activity because of her progression of her heart failure, struggle with depression, and has been more withdrawn since her husband died 3 months ago from an MI. So tell me in the first box, what relevant data do you guys have with the present problem?
Her history of an MI.
Okay, so, her history of an MI and her ejection fraction of,
15%.
yep, 15%. Good. So we're talking end stage. Are you guys talking end stage here? 15 EF? That's really bad. Okay, so we're talking end stage there. What else? What else in her present history?
Shortness of breath times 3 days, and then it's progressed. Or from activity to non-activity.
Absolutely. So now we're thinking, could she potentially be going into pulmonary edema? Yes.
I put that she has to sleep in a recliner sitting upright and she can only speak in like partial sentences.
100%, right? We want to be able to hold a conversation. You're like, she can only speak for like a few words. That's something very serious. And you just said orthopnea. So orthopnea is that big red flag, right? Orthopnea is a red flag for left-sided heart failure, you guys. Think of that patient that I have that picture of. He's leaning forward. Okay, good. Anything else?
Her legs are swollen.
You got it. Yeah.
She
So
gained 6
now-
pounds in 3 days.
Say it again.
She gained 6 pounds in 3 days.
What are we thinking with swollen legs? What side of heart failure?
Right side.
Very good. Yes, I love it. Okay, now give me her relevant data from her social history.
Her level has decreased over the last 2 years.
Right? Because she just, since her MI, right? Wasn't it her MI? I think the last 2 years, her level of activity has decreased. Good. What else?
She's depressed and withdrawn, and her husband just died recently.
Wouldn't that be scary if you had cardiac and then your husband died unexpectedly with cardiac? So you can imagine that. Okay, excellent. Next is your patient care begins. So take a look at those vitals. They're not terrible, are they? But look at that SAT. All right, well, you tell. I just gave you one of the damn answers. All right, tell me your relevant vital sign data. Tell me what you see.
Her pulse is 92, but it's irregular.
Rate of 92.
Yep, and it's irregular, right? So now we're thinking maybe some AFib, right?
Her
Okay,
respirations are 26.
okay, I like it because now she's trying to get more oxygen, right? Because now she's having a hard time breathing. Good, I like it.
Her blood pressure.
Because the more resistance, is it going to make it harder for the patient to get that blood out? Yes. We need to do what? Decrease the workload of the heart. Okay. And what else? What about that SAT?
It's less, well, it's 90% and she's on 6 liters.
She is, isn't she? And she doesn't have COPD, does she?
No.
It's not in her history that we know of, right? So she doesn't have COPD. So that's a big deal. And you're absolutely right. We're on 6 liters and we're only at 90. Like, what's that about? You know what I mean? All right. Current assessment. So I want you to take a look at that current assessment and I want you to tell me what is relevant in that assessment.
She has coarse crackles scattered throughout both lung fields.
Excellent. Keep going.
She has an S3 heart sound.
Good. What about her rhythm in her heart?
AFib.
Excellent. What about her skin?
She's got edema.
And her skin's cool.
Very cool.
So when we're talking about cool skin, we're talking about decreased perfusion, you guys. My skin should not be cool. I'm getting decreased perfusion to the periphery. You guys with me on that? So we already now know probably some decreased cardiac output. Anything else?
I put she's anxious.
Jinx, you owe me a soda. Yes, you guys said that she's anxious. And when we start thinking about anxiety of somebody who doesn't have anxiety, she actually has depression, we start thinking hypoxia, don't we? We start thinking, what the heck's going on? Why is this patient so anxious? She might be air hungry, you guys. So pay attention to that when patients' demeanor changes, okay? All right, anything else? Anything else in her assessment that you want to know about?
Did we say +3 edema?
We did, but excellent. Yes, that +3 edema. Yep, that's significant. What about that she doesn't have neck vein distension? So it's not that right-sided, is it? It's not right-sided, is it? Okay, so we're really looking at maybe the left-sided heart failure. What about her rhythm there? What do you guys think about that rhythm strip?
I'd say AFib.
Yeah, right? Because when you look at it, it's like that jaggedy line. There's not really a discernible PR interval, is there? And if you looked at the R to R, where the spikes come up, that's irregular. They're not mapping out in a regular fashion. And tell me about her diagnostics. What do you think about those?
Dr. Colmer, what about the S3 Gala?
What about it? No, somebody said it.
Oh, I'm sorry, I missed it.
No, I can't remember who did, but somebody did say S3.
Okay, I apologize.
No, but you're absolutely right. You definitely, that's significant, right? We don't Kentucky ourselves around Walmart, right?
Mhm.
All right.
Oh my
Now we
God.
have, oh, I'm losing my mind. Now we have, I've done lost my mind. Now we have, what is relevant in her lab values? Talk to me about that.
Her
said
being
Cadmium.
It's like schizophrenia. I'm hearing all kinds of voices. Okay. Somebody give me one.
Sodium.
Sodium. Okay, what about the sodium? What did I say about that?
I said it could be dilutional because of all the excess fluid.
Mhm.
Very common, you guys. Please pay attention to that. That's exactly right. I'm in fluid volume excess. It could be dilutional. Okay, great. Give me another one.
Her creatinine is increasing.
Ooh, what do you think of that?
Well,
Kidney
it's
She's
just-
on a kidney failure.
Or acute kidney injury. We can't quite say failure
Oh, okay.
yet. So that's
Okay.
language that we kind of use as acute kidney injury. But yes, you're absolutely right. And remember I said that heart and those kidneys, they go hand in hand. So she's probably had a decreased cardiac output for some time. What do you guys think? Because my
Mhm.
creatinine's up. You're absolutely right. What the heck is going on here? Okay, good. I like it. What else?
her potassium.
What do you think of that?
I mean, it's still within normal limits, but it was 4.2 and now it's 4.9. So
Oh, now look at that. So now you're starting to say, I know it's still normal, but it's trending. And my kidney function, that's a very important, what you just did right now is a very important thing. Even though that value is normal, you've recognized it's trending upward. And now we're making that connection to that kidney function. Do you guys see that? So
Mhm.
sometimes even when you have normal values, you need to say, ooh, what the heck happened here? And that's exactly right. Okay, what about the glucose?
She's improving with her glucose.
Pretty stable, wouldn't you say?
Yeah.
Okay, keep going. Give me something else.
Her BNP is high.
Talk to me about that. So what do we think?
It's compensating.
Mhm.
It's trying to. That's what the body does. So when we have an issue with fluid excess, BNP gets released to help us naturally diurese. So the higher it goes, it's trying to compensate. So to answer your question, it's trying, but darn it, we're still just sick. Do you see what I'm saying? It keeps getting released to help us, but the more I keep releasing it and I'm getting worse and getting worse and getting worse, it's not compensating. So you're right. It is a compensatory mechanism, but it's failing, isn't it? Because she's in heart failure now. Good. Give me something else.
Troponin.
What do you think about the troponin?
Getting worse.
It's high though, isn't it?
Mhm.
So do you think she has a heart attack?
Yeah, she's headed for one.
Well, remember, or maybe I didn't say this, but troponins can be elevated in kidney disease as well. And isn't she going into worsening kidney function?
Mhm.
So yes, do we worry about that troponin being high? It's staying high though, isn't it? It hasn't gone, it's sort of stable high. Does that make sense? So it
Mhm.
hasn't done crazy stuff. But think about kidney dysfunction as a cause of why that troponin would be elevated as well. Any other labs? Platelets look good, right?
Mhm.
Magnesium looks fine, but we definitely want to pay attention to magnesium because if it goes high or low, it can definitely affect the heart rhythm. If it goes high or low, it can definitely affect the heart rhythm. So if I have a low magnesium level, one of the first things that we look for is torsades. That's what I get for trying to eat and talk at the same time. Torsades. When I have a low magnesium level, we look for torsades, and that is a ventricular tachycardia. kind of a crazy ventricular tachycardia. It's very different than a normal ventricular tachycardia. You'll learn about this next semester too. But that's one of the first things that we look at. If the magnesium is low, we're looking for torsades. If the magnesium is high, it can sort of stun the heart and the heart won't contract as effectively. So it's never good to have a high magnesium either. It won't contract as strongly. It'll be kind of sloppy and lazy. What about our INR? Do you like it?
It's within normal limits.
Is she on any medications that it should be?
I don't have her med list.
I can give you your med list.
I don't think so.
No.
Well, I'll be damned.
I mean, we know she's
That's
on
what I'm saying.
furosemide and nitro.
This is a crock of crap.
All right, here's what I want you to think about. If she is on Coumadin, if she's on Coumadin for her AFib, which is common, the INR will be elevated. This is slightly elevated, 2.5.
Yeah, it should be 2 to 3 on Coumadin, right?
You got it. That's exactly right. You got it. So if I'm on Coumadin, I want my INR to be between 2 and 3. And she is. We don't know if she's on Coumadin, but we're going to find that out. We're going to ask that question. All right, let me flip. All right. What did you guys put for biventricular heart failure pathophysiology? What does that mean? And if you tell me both ventricles are failing, I'm going to come across the screen and all right, after tonight, I want you to read this because it's really important that you think about what does left-sided heart failure look like? What does right-sided heart failure look like? The answer key has a really short and sweet and kind of nice to the point of what it'll look like, and it'll kind of make sense to you. And I don't want to sit and read it because it's 3 paragraphs and you'll be like, I don't really care. Okay. Why are you giving oxygen to keep SAT greater than 92? What's your rationale?
You want to improve perfusion to the organs.
The oxygen won't improve the perfusion. When you say perfusion, think of blood flow. However,
Well, because you said she's like anemic right now, though, because she's not getting perfusion with the blood to the organ, so she has like decreased O2, right?
So it's delivery. It's not because she's anemic. It's because I'm not getting the cardiac output.
Yeah.
So I could have a normal blood count, but it's all going back into my lungs because of the heart failure. So she's not per se anemic. She's hypoxic because she's not getting the cardiac output. She's not perfusing. And those alveoli are filled with fluid. So we got to get rid of that excess fluid. That makes sense a little bit?
Yeah.
Okay. Why Lasix? What am I going to do?
Trying to get rid of excess fluid.
So loop diuretic, right? Causing diuresis.
Increase the urine output and hopefully it'll lower her weight.
Oh, okay. We're making those connections. We're evaluating those things. Okay.
Should help with breathing too.
Okay, because we're going to pull that excess fluid off, right? Okay, that makes sense. What concept?
Potassium might come down a little too.
Oh, well, look at you just looking at those lab values. Okay, that's right.
Decrease the preload.
Thank you. Whoever just said it. We're going to decrease preload. Kudos to you. That's exactly right. We're going to decrease that volume, that balloon stretch per se. We want to decrease that preload because the less that we're dumping in the heart, the less that it has to work, the less that it's increased demand for oxygen. It'll settle things down. So
Who said that?
I did, Tori.
Oh, you smarty pants.
I love it. Now, why am I giving nitro?
For a vasodilator.
Okay, Brianna, but what side?
On the
Good question.
right side, the venous side, right?
Thank you. So it's a venous vasodilator. So it's going to decrease what, Tori?
Afterload?
No!
At preload.
Preload. There you go. All right. On the venous side, because the veins dump
But wouldn't
back.
it also like decrease your afterload too? Because then your resistance wouldn't have to work as hard.
You definitely can drop your pressure, and you are 100% right, Elise, that it can. The principle of why we're given the nitrate though is to decrease
Less
that
volume.
preload.
Yeah.
But you're not wrong. Can it drop the blood pressure? Hell yeah. Yes. Yes. You're not
Now,
wrong.
I want to throw this in there. It didn't say that she had any chest pain. I know she was having trouble breathing, but if she had any chest pain, that would also assist with relieving that angina, right?
Yep. However you want to say it, whatever book you read or whatever person says it.
Angina, potato. Okay.
You're absolutely right. And the other thing is this nitro that we're talking about, this vasodilator, we want to get more blood flow to the coronary muscle, don't we, guys? The cardiac muscle, because of we have hypoxia going on with this heart failure. You guys get that? So if we dilate the coronary arteries, we're going to get better blood flow. Even though she didn't have chest pain, we're going to get better blood flow because that's what nitroglycerin does, is it dilates the coronary arteries and it'll help get better blood flow to the heart. Make sense?
Mhm.
What is so funny, Elise?
I don't know. You just remind me of my mom.
Oh, great. Oh, great.
I laugh at her. I laugh at you the whole time because you remind you're Italian. Yes, and so it's like I'm dealing with my aunts teaching me this lecture.
No, for real. Like I just see my mom like jump around the screen. I just can't deal with it right
You
now.
see why I miss you guys so much. I love, you know, if I was in class, I'd be walking around like a lunatic. Why am I doing strict INO?
So you gotta see if the therapy's even working.
Mhm.
Okay, so you want to see if the diuretics, right? We got to know. How am I going to evaluate the Lasix that you gave me if I don't know how much that patient peed? Everybody got that? Excellent. Why am I doing a fluid restriction?
Because she's already fluid overloaded.
Okay, right? And we don't want to increase, where's Tori? We don't want to increase.
Preload.
There you go. Because if I do excess volume, I'm going to increase the preload and then I'm going to, you know, the shit's going to hit the proverbial fan that's blowing above me and things will just spiral out of control. Okay.
And you also want to keep their electrolyte balance. So if you give them more fluid, it's just gonna like make
It
everything.
could potentially dilute them out. Yeah, I mean, this is a very fine line that you have to walk with heart failure patients because you're like, oh my God, I got to restrict the fluid. I got to watch the electrolytes. I got to watch this drug. This drug's going to drug, you know, it's a very, very fine line that you walk with these patients because you're right. A lot of these treatments could harm, could help. So definitely, you definitely want to pay attention to fluid volume status. All right, and the low sodium diet as well. Okay. Give me, let's do a nursing care plan. Yes. I have 7 minutes left, so let's do the care plan. Impaired gas exchange. What do you want to do for me? Silence.
Give oxygen.
Oxygen and APPs.
Okay, so let's go with the oxygen first. Increase the O2, keeping the SAT
Greater than
Above
95%.
92. He ordered 92.
Okay.
All right, somebody said ABGs. Yes, if we need to. What else?
Position and high Fowlers.
Oh, yes. Keep going.
Coughing and deep breathing.
Okay, keep going.
Instead of
Breath
spirometry.
sounds. I was gonna say more.
Yeah, breath sounds instead of spirometry. What about my pulse ox?
Continue.
Yes, thank you. Very good, very good. And don't we want to know circulation? So would this patient be placed on a monitor?
Mm.
Yeah. You all just said there's potential for arrhythmias. There's potential for all this crazy stuff to go on. So we're going to put them on a monitor. Excellent. How are we decreasing the workload of the heart? What are you doing?
Your Lasix order.
Giving medication.
Not the work. Lasix will do volume. Go ahead.
Nitro.
Nitro.
There you go. Nitro. And what else? What else is going to reduce my afterload?
Would a beta blocker?
You could, but remember, beta blockers aren't good to start with acute Yep, they're not, because they could cause heart failure. Do you know what I mean? So like,
Diuretics?
well, diuretics will help with the preload, not
Oh, whoops,
necessarily
I'm
with the
sorry.
load of the
ACE
heart.
inhibitors.
Yes, think of that afterload reduction. Yes, hydralazine, something that'll decrease that, how the heart has to pump against. Think of that afterload. Think of afterload. All right, so the excess fluid volume, what are you giving me?
Lasix.
Diuretic.
I like it. All right. Are you gonna give me something else since I'm diuresing so much?
Foley.
Thank you. Whoever gave me a Foley, because I don't want to have to pee like, you know.
Potassium.
I don't want you falling, getting out of bed. There, whoever just said that, that's exactly right.
You better have them yellow socks on.
I have a pair right here at home. No, when I had surgery, they put the yellow socks on me because I fall a lot. My husband told that nurse that I was so pissed. All right, psychosocial. What do you need to do?
No.
Y'all are like, we don't do any of that psychosocial.
No. I put care and empathy. Make sure you do your hourly rounds, making sure patient's comfortable. And if your patient wants to talk, like if they need to get something off their chest or, make sure you have listening ears, comfort them.
Good.
Talk to the patient at eye level.
Yep. So that you're not in this like authoritative position, standing over them. Okay. What else?
Would you do a depression screening?
It's probably not a bad idea because wasn't she prior to this? Like she had some issues. So I really don't think that's a bad idea. Now we're decompensating even more. Could she be spiraling out of control more and being more depressed? I would not disagree with that. What about spiritual?
Well, I put first, do they belong to a church? ? Because
Yeah.
you don't want to, I don't think you want to introduce spiritual stuff to a patient that might be a Jehovah Witness or an atheist, or you never know. So I
Yeah.
would always check first before
Yes.
you get in.
Is that a concept that they,
Right.
You don't have to necessarily follow a particular religion or church, but still be spiritual, right, guys? So really, whatever that looks like for the patient, that's exactly right. You don't just say, can I call your priest? And you're like assuming that they're Catholic because we're a Catholic hospital. That doesn't necessarily hold true. So you're absolutely right. It's really of what are your beliefs? Like what can I do to help you with this process? I definitely think that that's important and not impose whatever your beliefs are on them. Cultural, if applicable, let's see. What are you going to discharge me on? You're sending me home.
PO LASIK.
Say it again.
PO LASIK.
So you want to put me on some, okay, so I'm going to be on a diuretic. Okay, and we can't go home on IV. You're right.
Sodium.
Low sodium diet.
Want to do a low sodium diet. So it might be 1 gram, it might be 2 gram. Okay, fair.
Weigh daily?
Absolutely. So we don't get into that. You're 30 pounds up when you came in. So, and we call the doctor when?
When they're 3 pounds.
2 pounds.
It's overnight or
5 pounds.
Pounds in a week.
yeah. And you've got to be that specific with the patients because they're like, I gained 5 pounds. That's not a big deal. Yeah, it is. Yeah, it is. So
Well,
you
your doctor
yep.
for late signs of heart failure.
Yep. Absolutely.
Yeah. Take medications as prescribed, and make sure they're compliant with follow-up appointments. Very
Okay.
important.
Yes.
And I said the same thing as Brianna. I said signs and symptoms of heart failure, call if increase in weight, fluids, edema, shortness of breath, etc.
Yes.
Moderate hypokalemia.
What about hypokalemia? Oh, what do you want to do with that?
You better send her home with some potassium with that Lasix.
Right?
You could teach her how to like take her pulse and stuff.
Very important, especially with medications that are going to affect the heart rate, like your DIG. Yeah, that's exactly right. Or if they've got to get their blood pressure taken, whether it's an automatic cuff or maybe their family member take it, they have to know what their pressure is. I can't tell you how many times people would take their diuretic, and they come in their pressure's 70 over 30. And I'm like, oh my gosh, you know, we're backpedaling to try to help that patient who probably could have not had to come in if they would have monitored their vital signs. You guys did good. Yins are smart.
Today.
She's like, today. Okay, well, my time is up. I am not keeping you over. So is there any other questions before we go?
I just had a question about